Great. So my name's Erin Whyte and I'm one of the registrars here in Sheffield, snowy Sheffield. And I'm going to do a very sort of basic introduction to valvular heart disease. And then hopefully my co-talkers who fit the definition of specialist much more than I do will come on and provide a bit more information. So this is kind of going to be a bit more of a basic overview aimed more at the trainees who are on the call. So what I'm going to cover a couple of general pathologies, so infective endocarditis, rheumatic fever, and then a couple of valve-specific pathologies. And you can see that I'm kind of going to focus on the left side of the heart predominantly, so the aortic and mitral valve. That's not to say that there are no lesions on the right side of the heart, but they're relatively less common. So in the short period of time, I wanted to focus on common entities. And also aortic stenosis and mitral regurgitation have implications re causes of sudden cardiac death for those of us who are interested in post-mortem work. The histology is hopefully going to be covered in later sessions, so I'm going to focus more, like I say, on a very basic overview of the pathophysiology of these conditions. So we'll start with infective endocarditis, which, as I'm sure we are all aware, is a multi-system disease which results from infection of the endocardial surface of the heart. It's usually on a valve, hence why it's entered this presentation. The regurgitant valves are more at risk, and this is because there's turbulent flow damaging the valvular endothelium, which allows pathogen adherence. And I'm going to cover the pathophysiology of infective endocarditis on my next slide. Other risk factors, as you can see, include prosthetic valves, cardiac devices, congenital heart disease, intravenous drug use, HIV, and excess hospital healthcare interaction. So conditions that will lead to turbulent flow and/or conditions that will lead to immunocompromise and make colonization by pathogens more likely. The mitral and aortic valves are more commonly affected, and classically the majority are strep or staph, but the etiological agent varies with geography around the world and also risk factors. So there's a higher prevalence of Staph aureus and gram-negative, and I should say fungal, not fundal, pathogens in healthcare-associated cases. The classic example of IVDU users is the tricuspid valve with Staph aureus. And another important thing to point out here is that patients may not necessarily have a pathogen identified at presentation, especially if people have had early administration of antibiotics when they arrive in emergency care, for example. So histology and stains play an important role in helping identify causative organisms. So the pathogenesis of endocarditis, as I sort of touched on before, you have an abnormal valve surface and you have a bacteremia. And the bacteremia may be triggered by a range of things, classically things like dental sepsis or treatment, invasive procedures, and sort of intravenous drug use comes under that umbrella, or sepsis at other sites, from a meningitis or other nidus infection. So the pathogens then adhere to the damaged valve, and you get a nidus of platelet fibrin thrombus. And this leads to the proliferation of the vegetation. And I'll show you some pictures of this in a minute. So you get bacterial adherence, you get platelet aggregation, and there's also evidence in the literature of a role of a biofilm formation. So this vegetation may have local effects on the heart. So you get perforation of the cusps, rupture of the chordae, you can get aneurysmal valve changes, you can get abscesses, which can lead to catastrophic atrial valve, mitral valve regurgitation and cardiac failure. Or the other way that endocarditis causes morbidity and mortality is by embolization. So the vegetation is able to break off, and this is where you get the classic sort of med school signs of endocarditis that you memorize. It's like Roth spots, but peripheral infarcts, abscesses, and end organ infarcts, so stroke, septic PE, renal infarcts, splenic infarcts, and of course an MI. So all the it's a wide range of clinical effects that this can have. So these are some pictures that haven't projected brilliantly, but hopefully you can sort of appreciate that on the left we have vegetations on the valve leaflets, that sort of creamy yellow substance, and also on the right, just to appreciate how close together the atrial valve and mitral valve are and the implications that has. And here's another picture where you can see this sort of cystic cavitation in the vegetation, which is just sort of to illustrate how severe these findings could be. So that's infective endocarditis. The other form of endocarditis I wanted to mention here is non-bacterial thrombotic endocarditis. So as the name suggests, this is non-infectious lesions of the valve, but you'll still have rise to the embolic effects that I touched on previously. It has a similar involvement valve site, so mitral and aortic, and the risk factors for this are rheumatic fever, which we're going to come on to shortly, hypercoagulable states, malignancy, SLE, antiphospholipid, and trauma. And histologically, similar to endocarditis that we touched on previously, infectious forms, you've got your fibrin platelet nidus, but again, as the name suggests, you're probably not going to find microorganisms and not necessarily have that sort of acute inflammatory neutrophilic response. And this is associated with regurgitation as a consequence of the valvulitis and also repeat cycles of healing. So rheumatic heart disease, this is a condition that has had a massive decrease in sort of high-income countries. You can see there's a graph on the left, how it's declined in the States from sort of the early half of the 20th century to the later half, given improvements in housing, hygiene, and introduction of antibiotics. But it is still prevalent in children and adolescents in low to middle income countries, and you'll still see sort of residual pathology from older adults in high income countries who had rheumatic fever in childhood or younger, people who've emigrated from high risk areas, and also indigenous peoples in high income countries. So on the right, you've got a campaign that's targeted at Maori indigenous people in New Zealand about being aware of rheumatic fever. And it still causes 280,000 deaths a year in 2022, according to the WHO. So although I think when we covered it in med school, it seemed relatively historic, it's still something that has important implications, and so it's important to be aware of. So rheumatic valvular heart disease at a glance. So you have the acute and chronic disease. So predominantly disease of childhood, and it's group A beta hemolytic strep. And it starts with pharyngitis, so sore throat, hence why those initial, those posts I showed you on the last page flag up the risk of a sore throat. You get febrile illness, a rash, polyarthritis, and pancreatitis. And then you get a reaction with the valve, and there's a couple of cardiac manifestations of rheumatic fever, so fibrinous pericarditis, myocarditis with Aschoff bodies, and valvulitis. Now, Aschoff bodies, I said I wouldn't touch too much on the histology, but for those of you who haven't come across them or just come across the name, so it's a granulated structure with fibrinoid necrosis, and they do tend to disappear over time and are replaced with fibrous scars, but they can persist for decades. So finding one doesn't necessarily mean that there's active disease. And then we're moving on to the chronic disease, which I guess is more the focus of what we would see in terms of damaged valves coming to the bench, or damaged valves coming through post-mortem. So it's a long-term complication that's immunologically mediated, and it leads to stenosis and or regurgitation. And you'll see as I move through the presentation, it pops up a lot. So aortic and mitral valves are affected, mitral valve more typically. And you have the microscopic hallmarks of chronic disease, so fibrosis, calcification, fusion, and sort of one of the important things to be aware of when you're trying to see if rheumatic fever is a differential or a cause for valve disease is this thick-walled blood vessel appearance, plus minus chronic inflammation. So that's the two sort of general topics I wanted to go through. I'm now in my last sort of 5 minutes going to quickly whiz through aortic stenosis and mitral regurgitation. So aortic stenosis, I'm sure we're all relatively familiar with. This is the most frequent type of valvular heart disease in Europe and North America, and prevalent in an estimated 10% of those aged over 80. And it has significant mortality, including in non-severe disease, and there's a risk of sudden cardiac death. And the consequences of stenosis include heart failure, thrombotic events, arrhythmia, and infection. Surgical intervention is increasingly common, and it's increasingly common to have combined surgery with coronary artery bypass grafting or other valve surgery. So it's quite complex cases. And there's been a falling in in-hospital mortality. So as I said, it's not unusual for this to come through the bench. The most common cause of aortic stenosis is calcification of an anatomically normal valve. And it's not as simple as sort of wear and tear, like you might think of an arthritic process. There's an overlap with risk factors for atheroma, so smoking, dietary risk factors, all the things that you put down, diabetes, etc., for risk factors for atheroma formation. And the other thing to be aware of when we're thinking about aortic stenosis is the congenital bicuspid valve, which is one of the most common forms of congenital heart disease. It does have syndromic associations, and it can be associated with other congenital heart diseases. So there's a potential for screening in affected families. So these are on the left is quite a picture from quite an old book, but you can really appreciate the massive left ventricular hypertrophy in a patient who's had aortic stenosis. And on the right, you have the valve. So you've got the sort of 3 calcified valves, and the calcification starts at the base and sort of progresses to the leaflet. So you get a progressive loss of function, and you have a reduced area of reduced motion because of this calcification. And I touched on earlier about thick walled vessels in rheumatic fever. In aortic stenosis, you tend to get sort of neovascularization and thin walled capillaries. So there's that sort of contrast when you're trying to think about differential diagnoses. So this is just a nice picture of a bicuspid aortic valve, which is something that has variable clinical presentation. So there are a few actual clinical molecular markers to predict complications. But as we previously said, complications include aortic stenosis, aortic regurg, heart failure, aortic aneurysm, endocarditis, and aortic dissection. And you frequently have one cusp larger than the other, but there's a range of different anatomical patterns, which I don't really have time to cover, but you can look up if this is something that's of interest to you. So the final thing I'm going to cover is mitral regurgitation. So this is the floppy mitral valve, where you've got the valve billowing or prolapsing into the left atrium during systole. And the causes of this are sort of primary causes to the valve, so the floppy mitral valve, papillary muscle rupture or dysfunction, endocarditis, trauma, rheumatic fever again, or secondary causes where you sort of have functional changes to the rest of the heart which then impact on the valve. So left ventricular hypertrophy, cardiomyopathy, or coronary heart disease. And it may be sporadic, or there are also familial forms. And again, it's one of those things that either has a whole range of clinical presentation. So it may be quite benign, or it may present with significant morbidity or mortality, including sudden cardiac death. So as we've talked about earlier, anything that causes turbulent flow will predispose to conditions like endocarditis. You can get friction lesions, which are endocardial fibrosis because of the turbulent flow, and you end up with risk of arrhythmias, including atrial fibrillation, which could therefore lead to cardiac death or heart failure. So just a few quick photos here. So on the left, hopefully you can appreciate you've got sort of this ballooned cusps and elongated chordae, which on the right have ruptured. You can see the areas are pointing to those little stumps. And the valves appear very ballooned and hooded and have a sort of soft, translucent quality in contrast to the firm calcified valves that we were looking at when we were covering aortic stenosis. So that's all I wanted to say as a sort of whistle-stop introduction to valve disease.
This is hopefully not teaching too many people to suck eggs, really aimed more at the trainees, probably, than those of you who have been doing this for a long time. But hopefully a few insights into sort of my approach when dealing with valves. So obviously surgical specimens you're going to see more commonly if you're working in a cardiothoracic centre, but I'm aware that a lot of people won't be. So your exposure to valves is going to be more autopsy based. So I haven't really concentrated so much on the surgical specimens, but you can see here you've got, can you see a pointer on the screen at all? Not seeing a pointer. But you've got the surgically resected valves. You can see at the superior aspect of the specimens, the sort of surgical margin with the valve leaflet, and then the chordae coming down inferiorly. And pathology wise, I think in the little diagram, see there, you can see a lesion just to the edge of one of the valves. So unless you're working in a cardiothoracic centre, you're probably not going to see very many of those. So the focus of this will be more on the autopsy assessment of valves. And the first thing, as with any autopsy case, is having a good history. So does the patient have any history of cardiac failure or known valve disease pre-mortem? Have they had any previous interventions? And then sort of alluding to some of the specific pathologies, particularly the infective pathologies, any history of immunocompromise, intravenous drug use, especially in people with known cardiac valve abnormalities. And obviously preferably before starting an autopsy, as always, you should have access to the hospital notes, including any cardiology and cardiothoracic surgery notes if possible. And always great at autopsy is access to the echo reports if available. So very basic start at the start. External examination. So does the body in front of you have any evidence of cardiac failure, significant peripheral edema? Then there's obviously the thing we all like to get the medical students to do is to look for textbook signs of infective endocarditis. I was thinking it's quite fun to try and do fundoscopy on cadavers, but varying degrees of success with that. And looking for the textbook lesions associated with cutaneous sort of microemboli and microembolic phenomenon. Distinguishing those from some of the post-mortem artifacts that you might find on a day-to-day basis in the mortuary may be tricky. So obviously take everything with within the context of the case. Particularly something that we see where I work down in Plymouth is we've got quite a high rate of intravenous drug users. So identifying groin abscesses, evidence of previous intravenous drug use is very important in those cases, and in drug users and non-drug users equally. Cellulitis, osteomyelitis, looking at sources of infection in cases where you're suspecting an infective endocarditis, particularly in the elderly, people with pressure sores or peripheral ulcers is quite useful. And I usually take swabs at the time prior to eviscerating. So as well as swabbing any wounds or abscesses accessible externally, I also try to get blood cultures if suspecting an infective etiology prior to the evisceration. If we're unable to do that, normally try and attempt a subclavian stab, but as you may well know, it doesn't always go to plan. It's quite difficult to get blood out in many cases. So I get the APTs to open up the pericardium when they're eviscerating, trying to maintain a somewhat as sterile as we can keep field, and then aspirate cardiac blood as an alternative methodology for blood cultures. Interpreting blood cultures, obviously, post-mortem can be tricky because there's always the risk of contamination. So again, it's one of those things that I think you could have a whole day's debate and discussion about the utility of microbiology post-mortem, but my preference is to do it and then try and interpret it afterwards. Obviously, if you've got pre-mortem microbiology reports, blood cultures, etc., that's incredibly useful when you're writing up the conclusion. So APTs usually eviscerate the hearts. For those of you who are still doing your own eviscerations, this can be a tricky aspect to the procedure, especially if they've had previous thoracic surgery. Obviously, with the advent of endovascular techniques for treating valve conditions, the open techniques are less common than they were. But in the case of pericardial adhesions, which you can see here over the anterior surface of the heart, that can make evisceration tricky. So my practice is to go sort of from the posterior aspect from the base, which you can see inferiorly there. This is the posterior view of the heart, is to go through the pericardium there and start to strip it off and blunt dissect around, taking the adhesions down that way. And just taking care and attention as you would in a case of bypass grafting, anything like that. And sometimes, these patients may have had multiple procedures either at the same time or subsequently. So it's just taking a little bit of care and attention while removing the heart. So once it's out, just a little look at the basic anatomy there. So obviously you've got your 4 heart valves to evaluate, the mitral valve and aortic valve on the left-hand side and the pulmonary and tricuspid on the right-hand side. So I'm going to go through those individually. If you open up the left atrium, to expose the mitral valve. You can have a look down from the top, and a wise pathologist once said to me, the only way you'll be able to assess cardiac valves is if you remember to look at them in the first place. So I think there is a tendency, certainly as people progress on and get a bit quicker, to kind of cut through the valves without really thinking about them. So just take a few seconds or minutes to stop at these points and just have a look at the valve and see, is there any obvious ballooning or tenting into the atrium? Does it look normal? Are there any lesions that are identifiable prior to sticking a knife through the valve? Then opening up laterally through the wall of the left ventricle to expose the mitral valve, and again have a good look at the annulus, and then sometimes there's calcification around there. Look for any fenestrations in or defects around where the valve leaflets insert, and then you can look at the valve leaflets themselves, assessing for any lesions or degenerative changes. And then obviously you've got the chordae coming down and inserting into the papillary muscles, and just having that systematic approach through will ensure that you don't miss any obvious pathology, making sure the chordae are all attached and haven't ruptured, and that the papillary muscles are intact and inserting into the wall of the ventricle. Two ways you can then proceed. Everyone will have their own preference, but you can either open up through the anterior leaflet of the mitral valve to open up the aortic valve, or if you don't want to damage the leaflet of the valve, you can open up anteriorly along between the left ventricle and the septum to open up the aortic valve. And again, same principles apply, just a systematic evaluation of the where the valve leaflets insert, and then the leaflets themselves, and finally the leading edge, just looking for any lesions. Something that I do before opening up that is just to take a little finger and slide that up through the aortic valve, because at that point, if you've got a significant stenosis, you'll be able to recognize it straight away if you can't pop your finger up through the aortic valve. And then you can proceed on to crunch through it with some scissors. So there we go. Right side, the tricuspid valve again, opened up laterally through the right ventricular wall there, and you can see the trileaflet valve exposed. And again, a systematic evaluation through all those components, just ensuring that everything is intact. One thing you should also do, I tend to do, is to look on the reverse side of the valve for anything that may be lurking underneath, because if you don't look there, you'll miss it, any little lesions or emboli that might be hiding underneath there. And then up through the right ventricular outflow tract to expose the pulmonary valve. So then you've assessed all four valves in a systematic approach, which means hopefully you won't have missed anything. And if you're doing that at the time of a chat examination, then the examiner should be happy. Okay. This was a case just to note the importance, I think, of going through systematically. You can see here the papillary muscles just to the left-hand side of the picture, and there's an obvious kind of mottling where they're inserting into the myocardium there, and the transverse section from the same case here. You can see some very distinct areas of discoloration in the myocardium involving the papillary muscles. So just a reminder there of looking at every single component, and the fact that valve disease or cardiac disorders, infarcts, inflammation, etc., that aren't specific to valves can affect the papillary muscles and therefore affect valve function, and this was a case of sarcoidosis actually involving the heart. And there's a thrombotic, a non-infective thrombus on the valve there, and this obviously pretty easy to spot, and you're hopefully not going to miss that macroscopically when assessing the valves. And that was giving off little microemboli, which gave rise to these very distinctive, well circumscribed infarcts. Again, looking at the aortic valve prior to opening it there, having a top-down look through. So after you've popped your finger up through the bottom, have a look down through the top, and you can see here this is a bicuspid valve opened up there, and you can see the fusion of the valve leaflets, giving that bicuspid appearance. And then just a note on mechanical valves, obviously the slightly trickier in the mechanical valves to open them up. APTs aren't going to be very happy if you try and cut through those with your scissors. So my approach to these is to sort of reflect back the soft tissue and have a good look around the annulus and where the valve's inserted and been sutured in. Make sure there's no big holes in that. I know Martin's going to cover some of the complications of this in the next section, so I won't go too much into that. Safe to say, in this case, there was some thrombus around the ring there, which was sort of hanging off down into a coronary artery and causing a sort of propagation of thrombus into the coronary artery and a subsequent myocardial infarction. But I will pass at that point over to Martin to discuss complications in more detail.
So, obviously, if you have diseased heart valves, the tendency now is to do something about them, and has been probably since the mid-1960s, although the technology's improved, the valves have improved, the surgical techniques and anaesthetics have improved. So really, what could possibly go wrong with all of this? So, next slide, please.
You should have it there.
Any surgeon will tell you that, sorry? Any surgeon will tell you that whatever goes wrong is a recognised complication. Either a recognised complication is something that is known and it's just unlucky that it happened to him, and that's a recognised complication, or it's a complication that's happened and he's actually recognised that it's happened and has decided that he ought to do something about it. And I use he in a generic sense just to make sure I don't offend anybody. Or a recognised complication is it's some mistake that some other fool has made and he just happens to make the same one. And all of those things can apply. But one of the things is not to be bamboozled by your surgeon when he says it's a recognised complication. Okay, so next slide, please. So in approaching your case, and this will vary to some extent whether this is sort of a fresh one recently done or whether this is a more longer term outside, but do know your operation. You need to have an understanding of what the surgical procedure was, and probably the majority of cases will be relatively straightforward, either a single valve or a single valve and grafts, or just grafts on its own. That really is the bread and butter of cardiac surgery. But things are getting increasingly complicated, and the techniques involved and the technology used is getting more advanced. And the good thing is that they can usually keep their patients alive for 30 days, so it doesn't appear on their 30-day mortality statistics. Most cardiac surgery is still done on bypass, and this is what a bypass machine looks like, and there's a schematic of a bypass circuit. And really the only bit you need to worry about is the bit that's attached to the heart, with essentially the blood being drained out of the right atrium, going through the bypass circuit, oxygenators, filters, etc., and then going back in through the aorta. So essentially the whole of the heart is isolated. You're not perfusing your lungs. Sometimes you can get some backflow through the lungs and you have to drain the left side of the heart, but that's relatively uncommon. Next slide, please. So bypass, that's the standard cannulation. But with minimally invasive cardiac surgery now, bypass circuits can be set up in the periphery through femoral or subclavian cannulation, which allows then for the surgeon to essentially work in a bypass field, but you don't have all the problems with that. So when you're assessing these things, you need to know where your cannulation sites are, whether they're going to be central or peripheral. The typical ones will be through the right atrial appendage with a two-stage venous cannula into the inferior and superior venous cava, and then an aortic cannula into the ascending aorta. There are other sites of access into the heart, so any open surgical procedure on the heart, so this is really the valve cases that we're discussing, will have vent sites. So the heart has to be de-aired before re-establishing the circulation, otherwise you get problems with air emboli, either in the brain or the lungs or God knows where to do that. And the vent sites typically, depending on the procedure, can be at the apex of the left ventricle or more commonly these days in the right superior pulmonary vein. So you often find little sutures in the right superior pulmonary vein through that. When you're on bypass, the aorta is cross-clamped, and that allows the blood to go from the aortic cannula around the circulation rather than back into the heart, creates the isolated field. But there are risks in cross-clamping, particularly if you have a calcified aorta, of fracturing the wall and causing problems. In addition to these central sites, there will of course be innumerable lines, drains and wires associated with that. Nearly all cases will have 2 pairs of pacing wires on the epicardial surface. There are 3 or 4 drains, depending whether 1 or 2 pleural cavities have been opened. So if both sides are open, you tend to have 4 drains, and if they've only opened one side, just 3, with the other 2 lying anterior and posterior in the pericardial space to drain that. So all those things may or may not be present depending on how soon after surgery you're doing your examination. Next case, please. Next slide, please. So the number of surgical approaches. So for a straightforward aortic valve, there's a transverse aortotomy, which is done through the anterior wall of the aorta. So you can see in the image on the right, you can see the 2 cannulae pipe, the white pipes going into the right atrium and into the aorta, the cross clamp applied below the aortic pipe, and then an aortotomy being constructed below there. And that gives you direct visual access to the aortic valve. Normally, in a standard aortic valve replacement, the aortic valve leaflets are excised around the bases of their cusps. These days, the majority of these do not come to histopathology. The value of that is minimal, but a small percentage do come through where the surgeons are concerned. That's certainly the practice in our centre, and I think it's the centre in most surgical centres now. So valve pathology has become a bit of a dying art, sadly. But that gives you direct access, and then a normal heart valve will be sutured in, usually with 12 or 13 sutures around the edge, and then it's parachuted down on those sutures and sutured into place, and then the heart can be de-aired, checked, and everything is, and off you go again. And this may be done with or without grafts as well. Next slide, please. The approach to the mitral valve is through what's called Sondergaard's groove, and this is the groove in the roof of the atrium between the right of the atria, between the right and the left atrium. So they dissect down and into the back of the left atrium. And that gives you a view of the mitral valve, very similar to the one that Rob showed in his presentation to do that. And that atriotomy may also involve the roof of the right atrium. So you'll often find when it's sutured off that it's closed across the top of that. The mitral valve is then inserted in the same way. These days, they won't excise much of the leaflet because they will try and preserve what's called the subvalvular apparatus. So once you've put a valve in, what you don't want is your left ventricle dilating up, and preservation of the subvalvular apparatus allows the old chordae to act almost like guys on a tent to stop the left ventricle doing. So subvalvular sparing is the preferred way of doing mitral valve, but may not always be possible. Next slide, please. These days, certainly for floppy mitral valve, the mantra is to repair and not to replace. You'll all have grown up thinking the mitral valve has 2 leaflets. Well, of course, it has 4 because there are deep clefts in the posterior leaflet, which is the one towards the bottom. And there are 3 segments then as P1, P2, and P3. And then during the operation, part of the leaflet, usually P2 is resected, and it can either be a triangular or rhomboid resection depending on the exact configuration of the valve, and that redundant valve is then taken and sutured. You can apply neocords, that is, you reconstruct the cords by fine sutures that go between the valve edge and attached onto the papillary muscles, just like a normal cord, and you can find those are being put in as well. For the most part, although it's a sort of belt and braces, the valve ring is then reinforced with a annuloplasty ring, which is usually a C-shaped ring, with the opening of the C over the center of the anterior leaflet and the rest of it around the periphery of there, and that is just sutured down in place. And it's usually done prophylactically to avoid a further dilatation of the ring later in life, because it's much easier to do it, get it right the first time, and put it in that way. Next slide, please. Obviously, the valves get implanted. Number of mechanical valves. The original was the Star Edwards, the sort of ball cage valve. They are no longer used. High risk of clots and largely discontinued, but you do occasionally see them. The tilting disc valve we still see occasionally in patients, and they had a problem with strut failure. So the little bar that holds the disc would break, and that wasn't terribly good outcome. So the vast majority now of mechanical valves are the St. Jude's pattern bi-leaflet valves, and these are used in both the aortic and the mitral valve position. And of course, mechanical valves tend to be used in younger patients because they have a longevity that exceeds that of a tissue valve, but have the negative problem that you have to be anticoagulated when you put them in. So there is a decision, but older patients, which is increasingly the substrate that gets operated on, tend to have tissue valves which are don't require anticoagulation. Next slide, please. This is one of my happy days in the mortuary when I saw my second only Star Edwards valve that had been in situ working fine for more than 30 years. So just to tell you, they do actually occasionally turn up, but you'll be very lucky to see one. But that's the nice surprise you get when you open up the left ventricle. Thank you. Next slide. Lots of different patterns of bioprosthetic valves that are available. The classic ones are perimounted pericardial tissue, bovine or porcine, with a sewing ring around the edge that allows you to put them in. Most of them are put into the annular position, i.e. in the line of the leaflets, but you can put some certainly in the aorta in a supraannular position. But supraannular valves do have a higher risk of coronary artery occlusion, so they do have to be careful with those. Some of them are stentless and behave more like a TAVI valve that go in. And you can see that there are a whole range of different valves that go in. Next slide, please. Increasingly, we're seeing transcatheter valve placements, both largely aortic, but now we're beginning to do them in the mitral valve. These used to be put in either, there are a number of different approaches, but nearly all of them now put in through an arterial route. The initial ones often were put in through what's called a transapical route through the apex of the left ventricle, but they tended to have poor outcomes. And largely, if you're not fit enough to have one through the artery, you're definitely not fit enough to have one through a transapical route. But essentially, they're threaded in and then expand. Some of them, the early ones were balloon expanding, so you put them in and then blew up a balloon and expanded them into the position, and then took them out, took the balloon out, and it just sat there. Some of them are now self-expanding, and they tend to expand slightly more slowly and just fit themselves to the contours that are available. There is no excision of the valve leaflets when these are put in, so the valve leaflets are still there and pushed back into the aortic sinuses. And provided your aortic, the orifices of your coronary ostia are not set low, they should not occlude the coronary arteries. But if they are low arising coronary artery ostia, then you can occlude them with serious consequences. But these days, the imaging, both MRI and CT imaging of this in the preoperative phase has largely meant that everybody is aware of where those sit, but those are potential complications. Next slide, please. These are just an example of the types of stent TAVI type or peripherally inserted valves that you can see. Number of different configurations. The one thing is to be careful when you're handling these. They tend to have sharp barbs on them. You'll tear your gloves, you'll tear your fingers. Just be very careful about where they go. Next slide, please. So the complications that can arise, you need to consider all the surgical sites. You can get hemorrhage from them, be they atrial or from the access sites, from the aortic cannulation site. You can get aortic dissections as complications both of aortic cannulation and of aortic cross-clamping due to damage to the intima. And that can track into the aorta or back into the aortic root on occasion to do that. And as I mentioned, you get coronary artery obstruction. Next slide, please. But involving the valve, you get dehiscence. This is usually a late complication. The sutures pull out and the valve becomes loose. You then get a regurgitation, a paravalvular leak with regurgitation, or you can actually, the whole valve can work loose and flop around in the air, which is not good. You can get thrombosis of the valves. This is largely seen with the mechanical rather than the tissue valves, but can occur on both. As I said, the Star Edwards was particularly prone to this, but it's uncommon. You can get hemolysis. So certainly where you get regurgitation, either paravalvular or through the valve itself, which can occur, you get hemolysis. And you can get hemolysis on the leaflets of mechanical valves, even the St. Jude's valve, which can cause problems when it's severe. Occasionally you get ruptures of the insertion points. Go back one, sorry. I'll come on to that. Or you get misplacement. You can see in the picture on the right, this was a TAVI valve that was put in, and they managed to expand it above the aortic valve leaflet. So you can see the actual TAVI valve with its mesh surround. But instead of holding the valve leaflets back against the wall of the aortic sinuses, it's actually held the valve closed. And not surprisingly, as the valve opened, the patient just lost all cardiac output. And it's an irretrievable position. They could not get back in there and retrieve that to do that. So you can get misplaced valves from that. Next case, that aside. You can get ruptures of the valves. The aortic valve ring is relatively immune from rupture because it's a fairly rigid structure. The mitral valve ring is a bigger problem. If you ever look at sections taken across the valve ring, you'll realize that there is not a lot of tissue in a valve ring at all. And when you get calcification of the annulus, you often have to chip out the calcium in order to sew the valve in, and that further weakens the wall. And they put the valve in and then wean the patient off bypass and get catastrophic hemorrhage, which is usually on the back wall of the heart where they cannot get to it. And you just have to take the valve out and you have to put a patch repair in and then put another valve in. It tends to do very, very badly. That is what I call a recognized complication. It's the only way you can replace the valve, and it's disastrous when it happens. But mitral annular calcification is a problem. These days, it's well known about it on the imaging. You can put the valves in over the top of the calcification when it's not too severe. Next slide, please. Dehiscence happens. These are images. Those of you who can read false color flow images from echoes can see their jets going in the wrong place here. But we'll move on for that because it doesn't really help. Keep going. But what you can do is repair the leaks. So where they get paravalvular leaks, these can now be accessed remotely, and you can deploy buttons or things like the Amplatz devices to fill those spaces and reduce the amount of the leak. You probably never close them off, but you reduce the amount of regurgitation and restore the function to that. Next slide, please. So here's an example of one where there was a paravalvular leak. The false imaging in the top right, you can see the hole in the top left-hand corner over this mitral valve. Next slide, please. And these are the sorts of devices that you see, these little mesh devices. They were originally designed for closing remotely ASDs and VSDs, so plugging any hole in the heart where you've got flow you don't want it to go. But they also get used and deployed around valves and plug in the holes. But they can float off and they can embolize, which is usually not good. So they're quite useful things. Next slide, please. And of course, the big bogey of these valves is infection. It's really quite uncommon to get infections, but when it does happen, it's a major problem. This is a case I had recently. The picture on the left is the view of the right atrium, and the picture on the right is the anterior leaflet of the mitral valve, which you can see. And you often find with infections that are going around the valve rings, and clearly this is an aortic valve that's gone problematic, that they erode through. They can fistulate. Often fistulation, particularly if it's from the aortic root into the right atrium, is associated with sudden cardiovascular collapse, because they're just essentially pumping their cardiac circulation from the aorta back into the right atrium, and they develop horrendous pulmonary edema. But in both these cases, you can see it's starting to erode through into the right atrium, and also there's an abscess collection with hematoma forming underneath. And this is a valve that's been in for about 2.5 years at this point and grew a strep sanguinis. Next slide, please. And there you can see the valve that was put in there. The leaflets are severely distorted. There are vegetations on the surface of it. And you can see when I remove the valve ring from there, you can see in the center of the picture on the right, there's actually an abscess at the base. And this corresponded to where we saw the leaflet, and some fresh hemorrhage lying just above that. So this is one where there'd been an infection of the valve ring, and they've done that. The patient came in with non-specific symptoms, took a while to diagnose. Usually they get prolonged courses of treatments to sterilize this before you then have to do a redo operation. Operating in an infected field and putting another valve in tends to have a poor outcome. You need to try and sterilize these beforehand, but sometimes you have to go in and operate because of hemodynamic compromise. Next slide, please. And that's the valve when it came out, looking from the top and the bottom. And you can see it's just looking really, really unpleasant. And in fact, it had become virtually occluded by this massive vegetation within it. So it wasn't there. And this is a type of stented valve, like a TAVI valve, but it's put in surgically. It's actually called a Percival valve. Next slide, please. That's just the case of a thrombosed valve. Next slide, please. I don't want to run out of time. Hemorrhage is another problem. This is a case actually where they had a aortic root replacement around the suture lines. You can see the suture lines above and below. Actually, there's been resuspension of the commissures of the aortic valve. You can just see at the commissure towards the bottom that it's been resuspended there and sutured to hold it up in place. Actually, they had a bicuspid valve, if you look at the top bit, but it wasn't causing any functional significance. And as they'd had an aortic dissection, it was determined not to replace the valve at the time, which may, in retrospect, not have been the right decision to do. But when they bleed really quite catastrophically. And if they don't get them back into theatre, they go horribly wrong. Next case, slide, please. So other sites that can happen, as I've mentioned, hemorrhage from cannulation sites, vent sites, you get dissections in the aorta, coronary artery obstruction, which can be direct because of the valve or by suturing. Some surgeons used to sort of concertina the aorta down onto the valve ring, distorting the valve orifices, and particularly the right coronary artery was at risk. That tends not to be done, and reimplantation carries a much higher morbidity and mortality, particularly when in the setting of infection. Next slide, please. So the advice to me, if you have to do these, is probably one, don't do them unless you know what you're doing, but understand the surgical procedure. As Rob was saying, check the notes, especially intensive care. There's usually a wealth of information. Understanding the hemodynamic data on these patients often gives you clues to what's going on. Check all aspects of the procedure. The tendency is to go for the meat, i.e., it's the valve, therefore I'm going to look at the valve, and forget about all those other bits and pieces which can also cause complications. So I have a philosophy of working from the outside in. I check everything else before I go to where the surgical site is. So I would have checked the cannulation sites, I would have checked the cross clamp site, I would check the vent sites before I go and check, you know, the grafts or the valve. So it's the last bit I do. These are what I call dynamic autopsies. That is to say, once you've taken it apart, you can't put it back together again. And so if you need to demonstrate it or show it, it becomes extraordinarily difficult. And certainly when I'm doing these cases with trainees, I stand with them and take them through it so I can see it as it evolves. It's not one for them to present to me at the end. And if you do it that way and train them that way, the trainees will then learn when to stop and ask for help. And that's always the thing to do. I also recommend, as it is dynamic, taking photographs as you go along. One is you build up a really nice collection of interesting photographs of things that go wrong with surgery, and that's useful in talks. But two, if you then get challenged about something in an inquest, you've got photographic evidence, and this does occur from time to time. You know, things like the misplaced valve, it's really, really useful to be able to show, look, this is where the valve was. So that's a quick counter through the surgical autopsy, particularly relating to valves, the complications that can arise, and to some extent what to look out for. So I hope that's been helpful. So thank you all.